And thank you very much, David, for the introduction. And thank you very much, Chris, my good friend and colleague, for the invite to speak at this excellent conference. It's really a privilege to speak. And as David said, I really want to focus on data and how we deploy data in the fight against cancer. And I'm really going to focus as well on some of the work that Chris mentioned that we did together with the Swallows in relation to COVID and cancer, and particularly with head and neck cancer. Just moving on to the first slide there. Everybody see that okay? Just to start off with, for me, COVID was actually very much a personal experience. Unfortunately, on the 29th of March 2020, my uncle died of a COVID-related illness. And one of my colleagues, Edward Vodoliak, who's an oncologist in Croatia, while he was reaching out to me to sympathize with me on my loss, he said something that really struck me and really worried me. And he said the following: people are starting to fear a COVID-19 diagnosis more than a cancer diagnosis. And that statement really worried me, because anecdotally, we'd been thinking that the same thing was happening in the United Kingdom. And I talked to my good friend, Richard Sullivan, and he said, yes, he'd also heard that experience, but there was really no data out there to either support or refute what Edward had said. And so we published an opinion piece in the European Journal of Cancer, really to highlight this issue. But then we decided, okay, we really need to go and get the evidence and to collect the data and look to see what intelligence we actually could bring to bear on the situation to answer the statement that Edward had made. And so working with Harry Hemingway and Alvina Lai in the University College London, and we decided to start a data-driven collaboration. And it was in two parts. The first was to look at real-time data, so data from hospital trusts right across the United Kingdom. And then the second part was a modeling of the excess deaths that we felt were happening due to the adverse impacts of the COVID pandemic and the lockdown. So what did we find? As I said, we looked at hospital trust data from across the United Kingdom, and we decided to do a relatively simple study. We want to look at two measures that would really determine the effect of the pandemic on cancer services, but most importantly on cancer patients. The first thing we looked at was the 2-week waiting time for cancer referrals. So that's really an early warning system for suspicion of cancer. It's called, for example, in Northern Ireland, the red flag referrals. And what we found really shocked us. What we found was that 7 out of 10 people with suspicion of cancer were not getting referred to cancer specialist services, either because they were afraid to go to the hospital or to their GP, or that their GP wasn't open. Similarly, for chemotherapy, which we felt was a proxy measure of the health of the cancer treatment pathway, 4 of 10 cancer patients were not getting access to chemotherapy at the relevant time. So this is the first data in the United Kingdom that really drew the attention of government, academia, NHS and the public to the disastrous impact of COVID-19 on both cancer services and on cancer patients. Unfortunately, this disruption really we saw was right across the cancer pathway. So if you look here, we saw presentational delay, screening essentially stopped, referrals were significantly down, as I showed you, CT, MRI scanning, again, significant drops. So impact on presentational delay, on diagnostic delay, and also significant impact on treatment, particularly on chemotherapy and surgery. We also saw there was a significant disruption of cancer research, so significant impact in relation to clinical trials, but also many laboratories shut down, so discovery research, translational research was very much compromised. The second part of the study then was to look to see what was the impact on mortality. So what was the impact, for example, in relation to excess deaths of people with cancer? And we looked at 24 different cancers, looked at data from nearly 4 million citizens and through a linked primary and secondary care data set, again showing the power of data. We modeled different scenarios We used the real-time data that I showed you from the hospital trust to help us inform those different scenarios. And what we found was between 7,000 and 18,000 approximately excess deaths of people with cancer. If we look specifically at oropharyngeal cancer, you can see there a significant impact in relation to deaths, and I'll come back to that in the more detailed analysis we did on head and neck cancer. Similarly, we looked to see what was the impact of other diseases, other underlying health conditions that people might have, other comorbidities. And we found that there was an additional risk if, for example, the patient with cancer also had either cardiovascular disease or hypertension, obesity, or diabetes, or COPD, or sometimes a combination of more than one of those. So again, very significant impact in relation to what was happening, not only in that real-time analysis we did, but also in that prediction we did in relation to excess mortality. And then we look to say, well, what's the impact in relation to anticipated 5-year survival? We've been doing very well in the United Kingdom in relation to improvements in relation to cancer care and how that's reflected in better 5-year survivals. I just showed 3 cancers here: lung cancer, breast cancer, and colorectal cancer. And what we did was we assumed initially 3 months of disruption, which was conservative. And then we said, what would the effect be on potentially shifting the stage to being a later, more aggressive stage? And also what impact would that have, or predicted impact on anticipated 5-year survival? What you can see there is we're going backwards. So rather than going forward, as we would hope to have been doing, and have been doing for the last decade, or 15 years even, we can see there that we're going backward in lung cancer. You can see going backward a number of years in breast cancer, going backward so that we're only at the level that we were between 2011 and 2012. And for colorectal cancer, over a decade. So again, a very significant impact of the COVID pandemic and the lockdown in relation to what we're actually going to see in relation to future cancer survival. Data has also helped us, as well as highlighting what the problem was. It's also helped us in relation to supporting the recovery. Again, here's an example in colorectal cancer. We saw obviously big challenges in relation to loss of life, potential loss of life due to the impact of COVID. But what we found was that prioritization using fecal immunochemical screening or FIT screening can really avoid many of these excess deaths and also reduce the immediate requirement for colonoscopy. One of the challenges in the pandemic was different techniques that we normally use in terms of screening or early diagnosis. We weren't able to use them because they created, for example, aerosols, and the guidance was not to use them. The impact of that obviously is significant in terms of people who need to be screened because they may be at risk of cancer. So what we saw was that we can support the health system by prioritizing tests, but also identify the patients who really need the test so that that can be provided to them as a matter of priority. However, we still had a problem. Even though we were seeing evidence of recovery, as you can see here in this slide here, the recovery is not uniform. Different cancers, recovery was at different levels. You can see there breast cancer nearly back to normal, but for colorectal and for lung cancer, for urological cancers, different levels there. So again, particularly for urological cancers and lung, only getting back to 60 to 75% of previous capacity. This is some data from my colleague in Leeds, Jeff Hall, who I work with quite closely in DataCan. You can see there at that stage, 1,400 missing diagnoses in Leeds. And we're still monitoring the data. So following that science, following the data, using that to inform our decision-making. This is the overall data. And then you can see here in relation to those 4 cancer types. We also found that the impact on services has been catastrophic. This is looking at it in the context of endoscopies. So again, a common technique that we use particularly for GI cancers, but also for other cancers. And you can see there the impact. In April 2020, we only did approximately 10,500 endoscopies as compared to 110,000 in April 2019. So again, a significant drop, over 90% drop. Again, really showing the impact has been really catastrophic to our cancer services. And what you have to remember is every single number that I've mentioned so far represents either a person at risk of cancer, a member of the public who goes to get screened but doesn't get screened because of the lockdown and the impact of COVID, or a patient. So we have to remember it's not just numbers. This is very much individuals, citizens, patients who are being affected by the pandemic. So just to summarize again, just some of the data I've shown you there, significant impacts on referrals, on treatment, on clinical research, and also that risk of excess deaths in people with cancer due to the pandemic. Then I gave a presentation at a meeting that Chris was at, showing some of this earlier data. And Chris approached me and said, we really need to know what's happening in head and neck cancer. And I agreed with him. So we undertook a joint study together to really look at what's the impact specifically in head and neck cancer. I showed you some of the data that we pulled out from that excess mortality data we used, but we also did the same type of approach here in relation to looking at what was the drop in terms of cancer referrals between 2019 and 2020 due to the pandemic. And you can see there at its worst, again, very significant, 60% drop in urgent referrals with potentially suspicious symptoms. And we're still seeing the challenge of that in relation to cancer recovery. Again, if we looked at it in the 5-year projected survival, again, we know in head and neck cancer, we've seen improvements over the last decade. And again, you can see a 5% or 4% reduction in projected survival rate. And that unfortunately translates into 451 excess deaths, or the potential for 451 excess deaths. And really, what I said at the time, and I still hold with this viewpoint, is we've done so much to improve outcomes for many cancers, including head and neck cancer over the years. What we don't want is that work that we've done over 10 to 15 years to be really unwrapped in 10 to 15 months. The other thing I would emphasize, and we've emphasized this within our campaign, is just getting back to normal is not good enough. If people talk to you about getting back to normal, challenge them. And because our data show that getting back to normal is not enough. We probably need to be working at 130% of capacity in order to achieve getting actually responding to the pandemic in the most appropriate way. Okay, just trying to move on my slides here. Okay, so then just to show you some data on COVID, but also some general data on head and neck cancer in Northern Ireland. So again, we've seen a significant impact in relation to COVID, 20% overall decrease, so over the whole period in referrals. We also have seen that disease is becoming more aggressive. So we're seeing now stage 3 and 4 disease cases increasing significantly, now nearly 2/3 of all cases. Also an increase in 17.2% in stage 4 cases, and significant increases in cases that we're now planning for palliative care. And this is one of the reasons why, if you look at the presentation route for head and neck cancer in Northern Ireland, and it'll be pretty much the same in Wales, in England, and the rest of the United Kingdom, what you can see there is a lot of referrals come through the dentists. And the dentists are really good at not only looking at oral health, but also symptoms of oral cancer. Obviously, dentistry was shut down during the pandemic. So that's also another reason why we're seeing this impact in relation to head and neck cancer. And it's really something that needs to be addressed. The other thing to show you is we don't just use data in relation to COVID. Obviously, I've focused on it in the context of this talk, but also it's really important to use data to derive the cancer intelligence that we can use to understand other aspects of head and neck cancer. We can see here, for example, just the data in relation to cancer and deprivation. And so what we can see there is a 57% increase in head and neck cancers in the most deprived areas compared to the least deprived areas, where we see lower incidence of head and neck cancer compared to the Northern Ireland average. And then we can just see here Belfast Trust, which is where I'm based, corresponds to the highest incident rates, whereas in the lower incident rates are areas with lower levels of deprivation. And this not only has been seen in Northern Ireland, but also elsewhere. And this work that I'm showing here is from Jerry McKenna and Anna Gavin, who directs the Northern Ireland Cancer Registry. So again, highlighting really the absolute critical importance and primacy of data and using that data to translate into cancer intelligence. Unfortunately, COVID, just like cancer, doesn't respect national borders. And we know that, and we now have brought this data, we brought this data to the European Cancer Organization, which is Europe's largest multidisciplinary cancer organization. They were really interested in this. We also presented it to WHO Europe. And the European Cancer Organization took our data so seriously that they immediately decided to launch a special network on the impact of COVID-19 on cancer. And I'm privileged to be a co-chair of that special network with Mirjam Krul, who's a pharmacist from Amsterdam in the Netherlands. We also found that as we presented this data and also looked to examine what was happening at the European level, that other centres were also looking at this approach as well in terms of looking at near real-time data. So we brought together a range of stakeholders from our patient advocacy group within the European Cancer Organization, the members societies, and also Community 365, looked at what were the challenges and delineate them much more precisely through the use of data. Also look at ways in which we can mitigate the impact and also produce recommendations and catalyze actions. And one of the first things we did was to develop a 7-point plan to mitigate the impact of COVID on cancer patients and cancer services. And this is the 7-point plan. Our 7-point plan, we said to build back better, but also to build back smarter. And what you can see there, the cancer backlog is at the top of the list. So this really needed to be urgently addressed. Second on the list then was restoring confidence. I mentioned earlier about citizens or patients being afraid to go to their either GP or their cancer services for fear of getting COVID. We need to really restore that confidence of both citizens and patients. We also need to look at ways in which we can tackle shortages, address the cancer workforce gaps. We have significant challenges because obviously we have to essentially repurpose our cancer service to be a COVID service, an infection control service. And again, how do we use technologies to our advantage? We've gone a lot in, for example, in relation to telemedicine. Some of that is good, although I still think there are challenges there that we need to address. I don't think we should go to a purely digital approach. I think a blended system is the way to go. And also highlighting here again the importance of data collection and that rapid deployment of cancer intelligence, and also working together, sharing best practice. And critically, cancer must not become that forgotten sea in the fight against COVID. Following the summit and the launch of our 7-point plan, various stakeholders approached us and said to us, would you consider running a campaign on the impact of COVID and cancer? We discussed it with the board of the European Cancer Organization, and we agreed, yes, this is opportune and it's timely to do so. And so we developed what we call the TimeToAct Campaign. Again, that has 2 parts associated with it. One is a data intelligence study to really look at the European level, what has been the impact of COVID and cancer, and then also using that then to inform the campaign itself. We presented our data intelligence study to the European Cancer Committee in May of this year. And this is just me summarizing some of the key data that we drew down from this study. So first of all, looking at the impact on screening and diagnosis, just draw your attention to 2 points. 100 million cancer screening tests missed. That's not a misprint. That's the actual number. 100 million cancer screening tests were not performed as a result of the pandemic. And then the impact on cancer diagnosis has also been extremely significant. 1 million cancer patients undiagnosed. So there's 1 million European citizens walking around there with a diagnosis of cancer that they don't know they have yet. The impact on treatment I've already highlighted before, but again, particularly surgery and chemotherapy, and also the impact both on citizens and patients in relation to attending screening appointments, going to their GP, going to the hospital for cancer treatment, but also looking at the impact on the workforce. It's really taken its toll on the cancer workforce. 4 out of 10 healthcare professionals feeling burnout, 3 out of 10 showing signs of depression. But again, although these are numbers, it's most important that we remember behind every one of these numbers is a person. And we have to remember that. And that's why we really need to act. The TimeToAct campaign is really appropriate. So time to act. Cancer won't wait, neither should we. We've translated our message into 30 different European languages. We've targeted 3 specific audiences. The first are cancer patients and citizens. Really don't delay. See your doctor if you have warning signs of cancer. So if you have difficulty swallowing, a lump on the breast, blood in your pee or your poo, unexplained weight loss, really you need to go and see your doctor. Also keep your screening appointments and your treatment appointments. And also remember, cancer services are safe. For healthcare professionals, again, supporting them, particularly as the Herculean work that they've done over the last 18 to 24 months, they need to be supported in relation to how we move forward together. But really, this message, and I'm not going to be shy away from this, this is a blunt message for policymakers, for health system leaders, for governments. Cancer has to be at the top of the agenda. We can't allow this to affect us in relation to our future, in relation to cancer services, cancer patients, cancer treatment delivery, cancer diagnostics. You know, this had an incredible impact, and we really need to, and that means that we have to resource it. As I said, we need to get back to 130% of normal in order to really address that backlog that I've highlighted during this talk. This initiative, TimeToAct, is patient-centered. It's been developed in cooperation with patients, co-created. It has pan-European relevance as well. So we launched a pan-European launch on the 11th of May, and then you can see the different countries that we've already launched in. We're hoping to launch in the UK in early 22, also in Ireland in early 22 as well. We've received a prize for this work in Spain for the campaign itself, and also we've also this work received the Royal College of Physicians Excellence in Patient Care Award. And that's not an award for us, that's an award for everybody. That's an award for the cancer community. And it's an award that's recognizing the impact that COVID-19 has had on cancer. So really would encourage you to engage with this campaign, to support the national launches. We have materials. Please contact me or go to the TimeToActCancer.com or our Twitter feed there. Every action we take now, particularly to address that cancer backlog, will help to save lives. So don't let COVID-19 stop you from tackling cancer. At the moment, we're developing a pan-European data navigator, which will allow people to look at what's actually happening right across Europe, look in your own country, look at different aspects of data. We're going to launch that later on this month at the European Cancer Summit. And again, we'd be very keen to work with you in relation to really getting this message across. So just to end then, I hope I've shown you, I'm using COVID as an example, but not just COVID, we've seen other examples as well, how we can use the data, unlock the power of that data, really to enhance cancer care for the cancer patient. Thank you very much for your time, and I'm happy to take any questions or comments.
That was really good, Mark. I've got to be honest, it was a fascinating talk, especially over a time when we've been very, very sort of distracted by COVID itself. And I think that has played in the hands of cancer care. It's caused trouble. We've got a number of questions from the audience. So I'll start, if I may, just going through them. Perhaps you can discuss them on live. So I've got a question that says, is there any support to hit the target of 130% to address the backlog?
Very good question. Thank you for that question. Yes, we've certainly received, people recognize, I think at the start, there was sort of this implication that we were going to be able to do all this with the resources we already have. And, essentially we poo-pooed that and said, you must be joking. That's not going to happen. So, for example, diagnostic centres are being set up, also looking at resourcing more, but there's still more needs to be done. And certainly sort of expecting to be able to respond to the pandemic using the same resources as we had before is just not realistic, particularly as people have had to add a Herculean effort in order to address just the impact of COVID in general over the last 2 years. But even though that message has been got, we still need to keep on pushing it, particularly sort of locally, to make sure, I'm work in Northern Ireland. We need to make sure that all 4 nations of the United Kingdom, get access to that, not just England, for example.
And that runs into a further question, that a couple of questions. It's what can the government do to help? And then additionally, how can we help as the people attending today help to spread the word?
No problem at all. Yeah, very much. One of the things we want to do is the launches we've done so far, all bar one, have been with the Minister for Health, so that they should take this seriously. And that was, as the Deputy Minister for Health, it was actually due to illness rather than any lack of commitment. And so we've been in contact with the Minister for Health's office here in the UK. We're actively engaging to hopefully have that launch in 22. I'd hope to have it before Christmas, but that hasn't been possible due to various things. So definitely at the government level, we need to see that level of support by actually participating. So it's no use just saying, oh, that's a great idea, but not actually engaging in it. And we see that as, then, because what we've done in other countries, Malta is a good example that I was involved in. The Minister for Health then took ownership of the situation and started to say, we need to do this, we need to do that. And that's exactly what we want, because obviously we don't have influence in Malta. He does have influence in Malta. So similarly, if they can do that. In terms of your people on the conference today, I'd encourage you to engage with the campaign. And we're certainly happy to look at ways we can work with the Swallows, for example, to amplify the message. Because that's what we see. It's a similar message that the Swallows themselves have articulated. And it's, we're all in this together. So it's the way in which we can best get the messages across to the people who matter, to the influencers. And the other important thing is it's a powerful message when it comes from patients.
So was that a question from you, Ali?
Sorry. I'm just posting things, so I was talking to myself. Apologies.
Oh, no problem.
But there's a lot of comments coming in about how...
There's a lot of comments coming in. So if I'm looking distracted, Mark, it's because I'm reading. I do apologise.
No problem, David.
There's a lot of questions sort of around the same point of why do you think the UK government isn't picking up the campaign until early 2022? I mean, as you said, it's sort of almost kicking the can further down the line if we're noticing a drop now. I mean,
I have to say I would tend to sort of I was a little bit disappointed that we didn't have now. Obviously, one problem was the initial engagement was with the previous Minister for Health, Matt Hancock. So there was obviously a delay then due to the change with Sally Java coming in. So I'll allow that for a while, but not for too long. So certainly we want to see, by January that we have a date for the launch in the UK. And the other thing is we would consider as well doing individual launches in Wales, Scotland, Northern Ireland, and England if that was felt locally to be something that would be useful. Certainly happy to do that. I've already had some conversations in Northern Ireland, obviously where I'm based.
Alice Cotton said, is given the question, how has the pandemic enabled new and innovative digital health interventions to improve healthcare of people with head and neck cancer? I mean,
very.
Please go on.
Yeah, very, very good question. And David, you might want to come in on this as well yourself. I'm not a head and neck cancer expert, but I think one of the areas which has been really important has been, the sort of digital consultations. And I said earlier that has been one of the things that's been really important as part of the process. But I do think, I've talked a lot to patient advocacy groups about this, while they feel some of it has been great and it's been really good, they don't want to go to a fully digital model. And the reason why is that you can judge different things in terms of people's demeanor when you meet them face to face. It's also easier to judge things like weight loss when you actually see the person. For example, I've found people I've never met before, and I've been interacting with them for the last year and a half on Zoom or Teams or whatever. One of the things I find a lot of the times when I meet them, most of them are a lot taller than I expected, because they're all hunched over these screens, and some of them I've been quite surprised that they've been quite taller than I'd expected. So I think it is important that we have that blend. I think there are some things you can do by digital appointments, but some things are really important that the patient or the citizen is in the clinic with the GP or with the cancer specialist. I think the other thing is looking at ways in which we can make systems work more effectively. I think one of the things that's happened is we very much pushed this idea of real-time data, and certainly NHS Digital then came out with a more rapid data set that people are able to look at it in much quicker. I mean, one of the challenges we face is we've had to make decisions very quickly in the pandemic. And in order to do that, you need to have intelligence that's available in a timely fashion. If it's 6-9 months out of date, it doesn't help us in terms of making the decisions we need to make now. I mean, so it's really important that we get accurate data, but also data in a timely fashion to underpin sort of digital interventions.
No, I think adding my side to that, Mark, I think you're absolutely right. Getting information that helps care right now is essential. So the speed of digital information is an innovation that is really important and should be pushed further. I think you're right. I think that virtual appointments have their place, but it won't get across eyeballing patients, especially in the head and neck arena where you're looking in dark spaces. You need a very special webcam to get there. So we'll move on to another question. There's so many questions at the moment. So a question from Peter Russell: putting data behind what we all suspected. Going back to the presentation title, do you have any actual examples of how joining up data from multiple organizations is improving treatment and outcomes?
Yeah, no, absolutely. So treatment, yes, we've seen it particularly at European level in relation to looking at ways in which we can actually combine some of the data that we collected and then use that to allow people then to make decisions as to where they invest in relation to cancer services. Outcomes is a little bit more difficult because obviously the timing is longer. So we can say predicted outcomes in terms of some of the data I presented. But one of the things we're now doing, because we're now sort of far enough into the pandemic, that actually some of the real data is coming on board that will help us to support that. I also chair the International Cancer Benchmarking Partnership, and one of the things we're actually doing with cancer registries across Europe is collecting that data now in order to inform what has been the impact, real time of COVID-19 pandemic on outcomes itself. And the other thing is, like, for example, the example I showed in relation to colorectal cancer, for example, before this pandemic, we didn't really have fit triaging in Northern Ireland as effectively as we might have. And it's actually improved that. It's meant that people have sort of almost leapfrogged into that approach now. So that's been a good impact for cancer patients from the COVID pandemic.
I've got a question from Richard Simcock, and his view is the hospitals who are best able to protect themselves from COVID were specialist cancer hospitals, and he's put examples of the Christie and the Royal Marsden. He said, is it time to start ring fencing cancer services away from acute hospitals or acute front door hospitals?
Challenging question. Really interesting that, because it's something as well we see. For example, one of the reasons why radiotherapy wasn't as effective as much, if you look at the data comparing it with surgery and chemotherapy, was that radiotherapy tend to be standalone institutions, and so weren't impacted as much as the other services due to the impact of COVID, because they weren't, people weren't being treated for COVID in the same place. I definitely think in terms of diagnostic centres, we should be thinking about that. I think that the challenge in relation to treatment is also, we also need access to other things, other parts of the service. And it's finding that balance between accessing other services and also being able to deliver the cancer service itself. So a little bit more difficult in the treatment stage, probably easier to do in the diagnostic stage.
No, I mean, I think that protecting the hospital and areas of the hospital from COVID has actually shown us a way to how to protect our elective, urgent services too. The University Hospital in Wales has a green specialist sort of theatre zone. So our capacity to do head and neck cancer cases has actually remained undiminished. So our diagnostic biopsies and our surgery has remained pretty similar to where it was before, but that's by an understanding of reprioritization and reevaluation of what your lists actually mean, protection, and an emphasis on cancer care and those that change health. So I think that it's not just away from front door, but protecting the services in those general hospitals too.
No, I'd absolutely agree with you, David. Absolutely right.
You're not going to get away easy with so many questions, Mark, I tell you. They're coming thick and fast. So Derek has a question. How is it possible that hospitals in the same region have IT systems that cannot share data instantly, and in some cases still rely on written information? Surely there is a restriction on quick action.
Frustrates the hell out of me, to be perfectly honest. So I would absolutely agree with that point. And we just have to keep on knocking on that door in relation to saying, we can't have the situation where we're essentially due to a technical thing, because we should be able to bring these together. I've argued a lot that we need to change our culture, and I think we still do need to change aspects of our culture. And we've really pushed that. We've pushed this idea of a cancer knowledge network that everybody can feed into. But it really drives me mad when there are systems that just won't talk to each other or can't talk to each other, or decisions have been made that meant that it's a sharing of data. It's not, we could even argue as much as everybody's now used to seeing COVID data every day. So why can't we see cancer data every day?
That would certainly make life a lot easier.
And then I go back to David, your point that we need, in order to make quick decisions, we need quick data. It doesn't necessarily need to be the absolute sort of deep dive data that we use in sort of cancer registration, but we need to have two systems. I think we need to have that sort of rapid system that gives us intelligence that allows us to make decisions, backed up by that deep dive data that gives us the perfect data set that we can then use to go forward.
What happens when the government stops having access to immediate sort of cancer data? Can you see the outcome of that? I guess it means sort of generally in the UK, but also with sort of the larger data well in Europe.
Yeah, no, it's a really good question, because one of the things, when we were collecting the real-time data, we looked on the 5th of June and just looked at our real-time data and the national data that was available at the time. When you looked at the national data on that date, the 9th of June, the 9th of June we looked at. When you looked at the national data on that date, there didn't seem to be any impact. But when you look to see what was actually the date that data was available from, it was available from back in March. So the problem was it hadn't seen the COVID pandemic yet, because the data was 6 months behind, whereas our data was 4 days behind and showed not only the drop and precipitous drop, but also the starts of the recovery. So I think, it's back to quick decision making. When you don't have data, it doesn't allow you then to respond, particularly to something like this. And that's why we didn't see a response straight away. So if we had rapid data, we would have realized straight away, we have a problem here. We need to respond to it quickly, rather than that delay period of 3 months before we actually knew where we were. And that was why we, for example, shared our data straight away with the 4 chief medical officers for the 4 nations and the National Cancer Director of Cancer before we even submitted it as a preprint, because we felt it was so important just to get that data out there and people to realize, we have a problem here.
Let's just see what other questions they have. Getting on to dental services, and I think most of us will have experienced a reduction in dental services over the pandemic. Shaila Anand asks, what is being done to help decision making to plan for dental clinical services in case of the pandemic? The importance of oral health needs to be highlighted for early diagnosis of oral cancers, as well as maintaining systemic health in those who have already went treatment for head and neck cancer.
Yeah, a really good question. I see another question by Jerry McKenna, which is a similar type question as well. This has had a huge impact, and I don't think the government really realised it when that the impact that, because the dentists do an incredibly good job in terms of that sort of screening in terms of for oral cancer, and then sort of refer people on, and that just pretty much disappeared overnight. And it's really looking at ways, and I suppose that get back to your point, David, and I think it's also mentioned in the chat there, is face to face has to happen in that situation, because you need to be able to do the analysis, the evaluation, to then say, I'm a bit worried about that, there's a lesion there, potential lesion there, and then pass on. So I really feel, and certainly in Northern Ireland, we saw it had a significant impact. Jerry and myself are doing some work together on that, actually. It's something I think that really people didn't think about at first. They were just thinking of dentistry in the context of dentistry, not in the context of cancer, and it's critically important. So that sort of screening in primary care is how we actually do our job. To be perfectly frank.
We've got 1 minute left to go before you get a break, Mark. I just wanted to ask you a question. Are we ready for the next pandemic in terms of head and neck cancer protection?
That's a really good question. I do worry that we think we're ready, but I still think we may have some things that we need to think about in terms of real responses. I think we've learned a lot. I think we're doing things different ways. I think some of them are good ways, but I think we need to say, what would be the 5 things we need, for example, if a different pandemic hit, in January, say, for example. And I still think we really need to think through that going forward.
Thank you very much for your time, Mark. It's been an absolute delight to hear from you.